You can, perfect. All right. So pathology board review for you guys. So I'm going to make up this history on the spot. Okay, let's see if you guys can do it. So let's see if you guys can come to an answer by combining a minimal history with the pathology. And if you cannot, then I'll give you more history, which will be much more leading and probably diagnostic by itself. So let's say lung mass, peripheral lung mass. Anybody with any thoughts? Peripheral lung mass in a 45-year-old woman, never smoker.
Looks kind of like adeno, the cells.
So you mean like there's glands here, like that one and this one and this?
Yeah.
So you're right that it's a neoplasm. Anybody, any ideas? How about a mass that's actually dangling on your radiologist tells you it's actually on the visceral pleura, not in the lung itself. It's a 5.5 centimeters, fairly soft tissue attenuation mass, and sort of sitting on the pleura. It is your radiologist
Like
says it's not in the
sarcoma
lung.
type thing?
Yeah, go for it. What did you say? Sarcomatoid what?
Some sort of sarcoma.
Some sort of sarcoma. Anybody else? Okay, I'll give you one more thing. It never really happens in real life, but this patient presented with hypoglycemia. Hypoglycemia, a single mass sitting on the visceral pleura, never smoker, female, and this morphology on pathology. Anyone? All right. I think if you're last chance. All right.
We
so
had someone in the audience throw out carcinoid.
Carcinoid. Okay. No, these are reasonable answers, but the clue here is that this tumor is these nuclei are elongated. Do you see that where my arrow is?
Yeah.
Elongated nuclei. So sarcoma was actually pretty close. These are elongated nuclei, but there's no mitosis, no pleomorphism, nothing. And then you have this, the collagen, you see that is rope-like wiry collagen between the tumor cells. This tumor is called solitary fibrous tumor. Have you guys ever heard of that? Solitary fibrous tumor? It's a solitary mass that sits on the visceral pleura. Most of them are actually, I mean, it is potentially malignant, but most of them behave in a fairly benign way if you remove it completely with adequate margins. Actually, hypoglycemia is known to be a sort of paraneoplastic thing that goes with this, but in real life, it almost never presents like that. It's just usually an incidentally detected lung. They call it lung mass, but it's actually on the visceral pleura. Questions? Anybody? I'll take one question for each one. Go ahead.
Can you circle the or use the annotation tool and circle some of those elongated cells?
Absolutely. So what do I do? Draw? Draw, right? Like this?
Yeah.
So this is an elongated cell there. Here's another. I mean, basically all of them are elongated, so it's kind of a thing to, it's kind of weird to circle them, but they are all. You see those nuclei? Those nuclei are the elongated, nuclei of the tumor cells. And this collagen is that wiry collagen that is very characteristic of this tumor. And then if somebody gives you a STAT6 positive in the stem of the question, you should know this is solitary fibrous tumor. The antibody is called STAT6, one of the best immunohistochemical markers in all of pathology. Very sensitive and specific for solitary fibrous tumor. Okay, guys, move to next.
Yes.
All right, let's go. So I always have problems with this annotation. It makes it difficult to get to the next slide. Okay, here we go. How do I get rid of these? Delete. See,
there should also be a clear all.
Yeah. Okay. All right, guys. Anybody want to make any guesses from the picture alone before I give you a stem?
PJP pneumonia.
Oh, very good, very good. All right, guys. So you need to just for your colleagues explain what you're saying.
On the H&E stain, you see the frothy pink. I think that's in your lecture your intro lecture, the other lecture we watched. It was the pink frothy of the H&E.
Beautiful.
And then on the GMS, it's highlighting those helmet-shaped or those spherical shaped fungal organisms.
Yes.
and then there's little black dots if we zoom in on the cytoplasm, and I think that's the how do you
little black dots on the H&E or on the GMS?
On the GMS, not the sorry, H&E has a little bit too, right?
Both. So within the froth, there are these little black dots. And even on the GMS, there's a little black dot. But actually, those dots are probably different things. They're not exact. They don't actually correspond to each other. But you're absolutely right about this. So, if you had a stem, you would get the usual stem for, HIV/AIDS, or somebody who's severely immunocompromised on corticosteroids, has bilateral ground glass opacity, severe hypoxemia. You guys know that stuff better than I do. But you've perfectly described the pathology of this. Remember that this froth has to be within the lumen of the alveolus. So it's not an interstitial thing. It's an airspace thing. Very good. Questions? Any questions? Anybody? No? All right, let's move on. All right. This is very annoying, this clear all drawings thing. It makes it difficult to... All right. Okay, guys, anybody from the picture, or else I'll give you a stem. "56-year-old man with bilateral lung masses, multiple. Okay, this man also has, these masses are cavitary. Many of the masses on both sides are cavitary. And a initial workup for, serologic workup, cultures, all that have been negative so far.
Is that a giant cell or a multinuclear giant cell there in the middle?
Yeah, absolutely. Yeah, you got that.
We're seeing an associated reaction with it.
So that's a multinucleated giant cell. Very good. Yeah, you're seeing a reaction with it. And okay, should I give you more of a stem? This patient also has sinusitis. And
it's vasculitis.
Yes, which kind? Which kind?
It's granulomatosis with polyangiitis.
Very good, very good, very good. Okay, so hopefully they will give you some sort of a hint in the stem. I think it's not really fair otherwise. But what you're seeing here, this whole area here is necrosis full of neutrophils. So this is called suppurative necrosis, that area that I just circled. And then the surrounding reaction is actually granuloma. So this stuff here, these are all epithelioid histiocytes. And of course, there's a big old giant cell there telling you, giving you a clue that this is actually granulomatous. So this is a kind of necrotizing granuloma with dirty, suppurative necrosis. Now, to make it perfect, I would have to show you a vasculitis too, necrotizing vasculitis, and then it would be GPA. But most people actually probably will not even have a picture of that. They'll probably have something in the stem which will clue you in like this, or will tell you ANCA positive, ANCA positive and bilateral cavitary nodules, hemoptysis, things like that. If they're very cruel, they'll tell you diffuse alveolar hemorrhage and give you a picture of capillaritis, which you will never be able to diagnose. It's very difficult. But hopefully they don't do that. Hopefully they're not as cruel as I might be. All right. Any questions, guys, about this picture and GPA? Pathology of GPA?
How would you differentiate this from other angioinvasive diseases?
Angioinvasive or angiocentric, you mean?
Angiocentric, sorry.
Yeah, so your classic angiocentric thing that's in the differential of this is lymphomatoid granulomatosis, which is or LYG, which is a kind of a lymphoma, EBV-driven lymphoma, and that can also cause bilateral lung nodules and sometimes can have extra pulmonary manifestations like skin, brain. So the classic thing about that is that really doesn't have granulomas. It has lymphocytes, lots of necrosis just like this, but lots and lots of lymphocytes. And somewhere in the pathology, they'll tell you that the EBV is positive, or Epstein-Barr virus encoded RNA, EBER, is positive. So LYG is EBER positive and is mostly lymphocytes and infiltrates the blood vessel, whereas GPA is a necrotizing granulomas and necrotizing vasculitis. That's the typical combination. The third thing, which is also involves blood vessel, is eosinophilic granulomatosis with polyangiitis, or previously known as Churg-Strauss. They're the predominant, like 99% of the inflammatory cells will be eosinophils. Hopefully the stem will tell you the patient is an asthmatic. and we'll give you some hint with the ANCA. But I think those are the three things: GPA, EGPA, and LYG to consider. Does that answer your question?
Absolutely. Thank you.
All right, perfect. Let's move on to the next one. I'm still not getting the hang of what I have to do to make this thing. Okay. All right, guys. Any guesses from the picture? I think we're a little bit behind schedule. We should have done 11 questions by now. All right. Any guesses from the picture? All right. This patient is a lung transplant recipient. Guesses from the picture? Anybody?
So there's an inflammatory infiltrate around the airway there.
Yes, very good.
And it's lymphocytic.
Perfect.
So the thing that comes to mind is lymphocytic infiltration post-transplant probably has a drop in his FEV1 in the stem. So they're kind of pointing toward the clad. And I think the clad they're pointing towards would be bronchiolitis obliterans.
Oh, okay. All right. That's where you went wrong. But you were doing really good till then. Very, very good. So you're doing really good with the lymphocytes. It is around a thing that looks like an airway, but that's not an airway. That's not an airway. This thing is a blood vessel. This thing here.
Oh, okay.
Those you can see the red blood cells in there, and these flat cells in the lining of it are actually endothelial cells. So for what you were thinking, you were heading down the right track. But if I tell you this is a small blood vessel and completely surrounded by lymphocytes, what would you think?
Rejection.
Yes, this would be acute cellular rejection, ACR. Yeah. That's what it shows. So you're looking for small venule-sized blood vessels, not capillaries, not these small, very small blood vessels. It's slightly larger. So venule-sized, arterial-sized blood vessels, they're surrounded by lymphocytes, just like you perfectly described. And then once you see that and you have the appropriate stem for an ACR, you can easily make this. It's very, very simple. As long as you can tell what the structure is, which is, for a airway, what you want is smooth muscle around it, ciliated cells in the lining of it. And you don't see any of that here. There are no ciliated cells, no goblet cells. So yeah, I mean, the other thing is, I'll remind you that if you see lymphocytes, you shouldn't be thinking bronchiolitis, obliterative bronchiolitis. Obliterative bronchiolitis is mostly fibrosis. So it's the lumen of the airway gets scarred out. It doesn't get inflamed out. So if you see a lot of lymphocytes, don't be thinking bronchiolitis obliterans or your bronchiolitis obliterans syndrome. Okay, so this was acute cellular rejection. All right, let's go to the next one, which is I think 4 or 5. Very difficult. This is impossible without a stem. So I'll tell you, this is a 85-year-old man with a unilateral pleural effusion. Unilateral recurrent pleural effusion. Any thoughts? You have the HNE and then the immunohistochemical marker, which is relevant here.
It's for mesothelioma, right?
Yeah, correct. I mean, obviously your stem would tell you more. It might tell you asbestos exposure, worked in a shipyard, this and that. Might give you some pleural fluid values. But the thing to remember, and I'll give you a little list, okay? And maybe somebody wants to write it down. So if you get a pleural fluid tumor with any of these positive, it's probably mesothelioma. So calretinine, CK56, which is what this is, and then WT1. All right, so calretinine, WT1, or CK56. If any one of them are positive, and by which I mean if the cells turn brown, then you're dealing with a mesothelioma. If I give you almost exactly the same picture, but any one of these three are positive, that would be an adenocarcinoma. So those would be TTF1, Claudin4, and MAC31, MOC31. So do you guys get that? There's like a panel of things we use, and if one side of the panel is positive, it's mesothelioma. If the other side is positive, it's adenocarcinoma. Any questions, guys? Because this thing is very technical and confusing. Questions? Ask me.
This is isolated from on cytology. These cells.
Yes. So you can. So this kind of appearance you would get either from cytology or from a biopsy of the pleura. You would have the same thing. You'd have malignant epithelial cells that could be either mesothelioma or adenocarcinoma, and then need to be sorted out by immunohistochemistry.
Awesome.
Okay. All right, guys, let's do the next one. So any guesses from the picture? No, 78-year-old man with a known diagnosis of multiple myeloma presents with bilateral pleural effusions, um, um, and bilateral hazy ground glass infiltrates in all lobes that were initially thought to be heart failure. The patient was diuresed and nothing, it didn't change. So this persistent ground glass opacities bilaterally, patient with myeloma, elderly guy, and bilateral pleural effusions. This is a lung biopsy.
Amyloid deposits.
Very good. Oh, beautiful, beautiful. I admire a clinician who can make a pathologic diagnosis. It's really amazing. So yeah, yes, you're absolutely right. So this stuff, this eosinophilic pink thing, all these globs are amyloid deposits. Now, what could they do to make it easier? They can show you a Congo red stain, which would be an orange pink color. That's called salmon pink. So the Congo red would turn orange pink, or they could show you a polarized Congo red stain, which would be apple green. So if you do look at it under polarizing lenses, it changes color from the salmon color to a green color. Or they could tell you, patient has already amyloidosis. That would be too easy, I think. But if you see these pink globs in a stem that sounds like it could be amyloid, and in this case, it would be diffuse alveolar septal amyloidosis, then I think you can make a fair guess that these pink globs are amyloid. Questions, guys? Very good. Any questions?
How would you differentiate these pink globs from fibrotic changes?
Yeah,
on
so
H&E?
good question. So Congo red is positive in amyloid, but is not positive in fibrotic deposits. So it neither turns the salmon pink color, nor does it turn green when you polarize it. So it's completely negative. Actually, when you polarize it, actually turns white if it's collagen. Does that answer your question?
Yeah.
Yeah, that's why we use the Congo red stain, because fibrosis can look similar to this. All right, very good question. All right, let's go to the next one. Guesses from the picture. By the way, guys, I purposefully mixed these up instead of going theme by theme because I don't want you to be, just guess it from what theme we are doing. So I mixed them up. Yeah. Guesses? Yeah, go ahead.
Pulmonary adenocarcinoma of the lung.
Wow, this guy should be a pathologist. This is very, very good. This is very good. So let me annotate it here for you guys and just show you. So he's absolutely right. So the things you need to make an adenocarcinoma diagnosis is you need malignant cells and you need something that is that you can buy as a gland. So these cells here, these are the tumor cells. These are malignant cells. And that, of course, is not within your, nobody should expect a clinician to tell a benign cell from a malignant. That's just too much to expect. But these cells are malignant, and then there should be some sort of a space that the malignant cells surround. So this is the space here. This is the actual space. So this whole thing is a malignant cells surrounding a space, and that by definition is adenocarcinoma. All right, so that's what this thing is. Now, this doesn't tell you it's a lung primary. It doesn't tell you, what growth pattern of adenocarcinoma it is, or, it does. There are many other things that you need to know. Is it a primary or a metastatic? Is it positive for this or that? But it does tell you right from the H&E that this is malignant and it's gland forming. So adenocarcinoma by definition. Questions? Anybody? There's a lot of questions that we can tackle about, primary or metastatic and growth patterns and prognosis and whatever. Anything? Anybody? Questions?
The structure that it's encircling is the airway, correct?
What's that? Sorry.
The structure in the picture is an airway, correct? That they're circling.
No, the structure, it's all tumor. There's no airway here.
Okay.
Yeah, there's actually no normal lung in this picture at all.
Got it.
Everything that looks here like an airway is all malignancy. It's adenocarcinoma.
Got it. Okay.
And actually, the reason it looks like airway is that the tumor is trying to recapitulate lung structure, but it's not.
Gotcha.
It's not lung. It's malignant cells trying to look like lung.
Got it.
Yeah, good question. Yeah. Anybody else? What is a classic stain for primary lung adenocarcinoma? You should know at least one of them.
TTF1.
TTF1, very good. And do you know any other stains for any other sites besides TTF1? What would it be if it were a met from the colon? Maybe too much for this group, right? But there's a thing called CDX2.
CDX2.
Can primary lung adenocarcinomas be negative for TTF1?
Primary lung adenocarcinomas?
Yes,
No.
primary lung adenocarcinoma that's arising in the lung. Is it always positive for TTF1?
I believe it's like greater than 90% of the time.
It's about 80%, yeah. So the answer is yes, they can be negative for TTF1. So just because an adenocarcinoma is negative for TTF1, it doesn't mean that it's not a lung primary. Do you guys get that?
Yes.
Yeah. Okay. All right. If you don't have any other questions, I'll move on to the next one. Clear all drawings. All right, let's see. All right, guys. Guesses from the picture. Otherwise, I'll give you a stem. And I'll give you 3 seconds. 1, 2, 3. Nothing? Okay. 65-year-old woman with COPD, 45 pack year history of smoking. Now comes in with confusion and dizziness. Was imaged and found to have brain mets. And when she was underwent chest CT, she was found to have a big hilar/lung mass.
Is this small cell?
Yes, correct. Okay, man, I really had to go deep into that history too. All right. So this is small cell carcinoma. You're very correct about that. So I'm going to annotate and just show you a couple of things you should know about that. So this thing here is a tumor cell with a mitotic figure in it. Do you see that little caterpillar looking thing in it? This is another tumor cell with a mitotic figure in it. So one thing about small cell carcinomas is they should have lots of mitotic figures. That's called high grade. It's a high grade carcinoma. The other thing is the tumor cells are all nucleus. There's barely any cytoplasm. So see what I'm circling here? All this purple stuff is all nucleus. There is cytoplasm, but it's so scant that you can't even see it. It's basically not there. And because they're like that, they touch each other. There's no cytoplasm to hold them apart. So they almost like they spoon with each other. It's like they touch each other like that, and that's called nuclear molding. It's nuclei that conform to the contour of the other nucleus. So nuclear molding is just a consequence of these cells not having, having very, very minimal cytoplasm. And that's a very good feature for small cell carcinoma. So if you see this kind of a purple look and you have a smoker, you can pretty much, and if you see a mitosis or two, you can be sure that this is small cell. What paraneoplastic thing might they give you for this? Anybody?
SIADH.
SIADH. That would be, yeah, and it's actually pretty common in practice too. So that would be a very fair thing to say. Say, give you a sodium or tell you the patient has SIADH.
Are there any special stains we should know about small cell or?
There are many, but I don't know if you should know about them. I would.
That's fine.
I'll tell you that there are these small cell carcinomas are neuroendocrine in nature, so they should be positive for neuroendocrine markers. They are not always, but the ones you should know are synaptophysin and chromogranin. That they might put that in the stem to tell you that it's a neuroendocrine tumor. So synaptophysin and chromogranin. Okay, guys.
Awesome.
All right, so let's clear that. All right, guesses from picture, very difficult, but I'm going to give you 5 seconds to try. 1, 2, 3, 4, 5. All right, next, what's that? Sorry?
I know we're in the lung.
We're in the lung. We're definitely in the lung, and I'll tell you the lesion is this thing here. So
Yes,
this is a lung transplant recipient. Guesses?
I think that's a big granuloma that we're looking at.
That's a good guess. Anybody else? Anybody? This patient has is about 3.5 years out, and the FEV1 has been dropping over the past couple of months.
Yeah.
This is what we mentioned earlier.
Yes, correct. So
This is
this is
bronchiolitis.
called, yes, so this is called obliterative bronchiolitis. So what's happening here is, you see that little layer on the, should I annotate it? Wait, just give me a second. So this thing here, this is smooth muscle. These are smooth muscle bundles. So this is the smooth muscle of the bronchiole, including this and that and this. So this is all used to be a bronchiole and used to have a lumen in the middle, right? That's the lumen of the airway. That lumen is completely gone because it's replaced by this collagen. It's completely scarred out. And now there's no hole in the middle of it. So it's completely obliterated the lumen of the bronchiole. So this is called bronchiolitis obliterans or obliterative bronchiolitis. And the clinical syndrome that's associated with it, dropping FEV1 and the ground glass opacities and the increasing dyspnea, is called the bronchiolitis obliterans syndrome, or BOS. Not to be confused with bronchiolitis obliterans organizing pneumonia, which is the older name for organizing pneumonia. Completely different thing. Does not cause any of this luminal obliteration of bronchioles. So it was a good idea to change the name of that to just organizing pneumonia so that it doesn't get confused with this. So questions, guys? Any questions about obliterative bronchiolitis?
I do have one question. Bronchiolitis obliterans in the setting of transplant and bronchiolitis obliterans in the setting of something like rheumatoid arthritis that's non-transplant. Would they look histologically similar?
Yeah, this is a really, really insightful question. Actually, if you ask me my honest opinion, I don't think that they are similar at all. I think they're completely different. So classic obliterative bronchiolitis that every pathologist would agree with only happens in the lung transplant setting. And it's very easy to prove and diagnose. The one in rheumatoid arthritis is actually more luminal narrowing, and it doesn't really ever get obliterated like this. So, you have a bronchiole with a lumen, and that bronchiole gets inflamed, and the lumen gets narrow. I think that's what they call bronchiolitis obliterans there. It's not true obliterative bronchiolitis like this, at least in my experience.
Got it. Thank you.
Yeah, great question. Same with, popcorn lung and this and that, other things that are alleged to be causes of obliterative bronchiolitis. All right, guys, move on to next. How are we doing with time? We're at 1:28. Okay. All right. Yeah, I'll give you one shot with the picture alone. Come on, guys, this is super easy. You have to get this.
Alveolar proteinosis.
Oh my God, so good, so good. You guys are so good at this stuff. I'll tell you, not all places are have fellows that are good at pathology. So this is a very good guess. So you tell us, you tell your friends why you call this alveolar proteinosis.
So we see the airway, the barrier there, and then inside of the airway.
No, wait. No, it's not an airway. There's a different.
Well, sorry, these are blood. No. So that isn't that the pink stuff is all of the proteinosis inside the lumen of the airway, correct, Dr.
No. So what's the lumen of the alveolus?
Alveolus, my bad. Yeah.
Yeah. What is the lumen of the alveolus called? That's what I'm getting at. It's not an airway, right?
Oh, so sorry. I meant to say I'm using airway and alveolar. I meant to say the alveolus or the
airspace. That's called an airspace.
Sorry.
Yeah, it's the alveolar lumen.
Airspace.
Right? The airway. So tell me what an airway is. So just so I know you understand, what is an airway?
Airways are the conducting parts of the lung, which
correct.
take
so you
take
have
air
to
to
be
that.
in a bronchiole or a bronchus. Correct.
Yeah.
So this is not an airway.
I apologize for the terminology. Yeah.
No, it's okay. I realize for you guys it's not a big deal, but for us it's the difference between a hallway and a room. It's very different for a pathologist. The alveolar lumen is the
thank you for clarifying that. Yeah. Thank you for clarifying that. But we see that the alveolar lumen is completely filled with the pink frothy, and then on H&E that can be protein is a one, and then you can do a special stain to highlight that and prove that that's what it is. But the way that it's uniformly kind of all involved, that's kind of where my mind went.
Yes, very good. That's it. So tell me one thing. Why is this not pneumocystis? I mean, this kind of frothy thing, you saw it in that case too, right?
Yeah.
The pneumocystis, I think there's more of the you could still see the airway as well. In this one,
Again,
it's
no airway. There's no airway.
sorry, the airspace.
Yes.
You can
yeah.
still see the airspace, and there's still some sparing of the airspace. There's some areas that are there,
That's
but this
true.
one,
That is
the
correct.
diagnosis is completely taken over.
I'll tell you a couple of like more, these are very, very pathology dense things, but I'll tell you a couple of things. So if the interstitium, the alveolar septa, is completely normal, like completely thin like this, that favors alveolar proteinosis. If the material that's there does not have those dots that you saw in pneumocystis, that favors alveolar proteinosis. And if you have in those alveolar proteinosis, these chunks of pink material like this, these are basically chunks of surfactant, then that favors alveolar proteinosis. And then, people say this to do the stain, but that stain is completely useless. What is the stain? You should know because it will show up on your boards. What is that stain we're talking about?
PAS positive. PAS positive.
PAS with diastase. And does anybody know what it means? It's another ridiculous thing for you guys to remember, but does anyone know?
Periodic acid.
Too good. I'm impressed. Yes. Periodic acid shift, which in one of my teachers used to say the PA stains everything from spit to, and then another word that I can't say here because it's a rude. Yeah, I won't say it. That's how good that stain is. Okay. All right. So very good diagnosis, alveolar proteinosis, and in the STEM, you guys know what they'll give you. This radiology out of proportion to symptoms and bilateral ground glass opacities, crazy paving pattern, all of that stuff. All right. So very good. All right, guys. I think this one is also very easily doable from the picture. Let me know if you need a STEM. I'll give you a STEM. 69-year-old smoker with a 5-centimeter cavitary lung mass in the right upper lobe.
Squamous cell.
Yes, very good. Very good. Very good. So why did you say squamous?
Is that mic on, Justine?
Okay, now it's on.
Oh.
Yeah, it has a pink swirly, like pearl-like appearance.
Yes, that's
it's
exactly
amazing
right.
for this.
Very good. Very good. So that pink swirly thing is actually keratin. So the tumor cells are making keratin and it whirls around like that swirly, just like you said. Then the cells have a lot of pink the tumor cells, pink cytoplasm, but between adjacent tumor cells, sometimes you'll see this like zipper-like thing. Those are intercellular bridges. So each line that goes across like this are intercellular bridges, and that happens in squamous cell carcinomas. So you obviously you shouldn't be, expected to know such granular detail, but the swirly thing, the history of smoking, cavitary mass, I think that's enough to call it squamous cell carcinoma. Maybe in the STEM they'll say hypercalcemia as a thing, Anything else? Anybody? Questions?
Good to go.
All right, very good diagnosis, guys. Let's move to this. This is more difficult. So give it a shot. If you don't get it, I'll give you a STEM. Anybody? This is tough. I think most pathology residents would also struggle with this, would not get it. All right, let's do, let's say 37-year-old woman with cough and shortness of breath for the last 3 weeks, was seen at an outside hospital, thought to be community-acquired pneumonia, treated with antibiotics, but the infiltrates did not resolve. A lung biopsy was performed. CT showed, now CT now shows
pneumonia?
bilateral, what's that, sorry?
Organizing pneumonia?
Yes, perfect. That's exactly what I was getting at. So, this is the classic history of organizing pneumonia. Somebody who's thought to have a, community-acquired pneumonia, they treat it, it doesn't go away. And what's happening there is that the neutrophilic infiltrates are now being replaced by fibroblast plugs, so the alveolar lumens, not airways, alveolar lumens that were filled with neutrophils and debris and bacteria are now being filled with these plugs of fibroblasts. So let me just quickly show you what that is. It can be tricky to tell this on pathology, but this is a plug. So let me trace it out like that. Then it goes like this. Can anybody tell me why it's branching like this? Why is this plug so serpiginous looking? Anyone? because it's following the outlines of the alveoli, so it's going from one lumen to another, through the pores of cone to another. So that's why it branches like this. And so inside this plug or meson body, there are fibroblasts, there are plasma cells, lymphocytes, and some histiocytes, just inflammatory cells. And this thing is very benign, very benign. And as you guys know, when it's idiopathic, it can be corticosteroid responsive. And it's good for the patient to have this rather than some bad thing like adenocarcinoma or worse. Questions, anybody?
How are they going to describe sometimes they give us a picture and they know that we don't know what it's showing.
Yes,
and they'll use descriptive words to describe what the meson bodies are. How would you
very good. Very good question. So they might say, if they were me, they would say fibroblast plugs or plugs filled with fibroblasts and inflammatory cells. But some people don't use that terminology. They say granulation tissue or organizing granulation tissue, or they say capillaries and whatever, or they might just flat out say meson bodies. But look out for that term. Sometimes people will describe this as granulation tissue, which I don't think is correct, but they, boards are not necessarily about who's correct, it's just what they want you to say. All right.
Thank you.
Very good question. Anything else? We are doing, I think, okay on time, but I'm slightly behind. I could not do one per minute. It's too fast. All right, let's do this, guys. Look, radiology.
Our favorite.
All right, between that and this, can you guess? It's difficult, but I'll give you more clues.
So we know it's a fungus, and then we have a GMS stain. The fungus are black. Then we ask ourselves, is it yeast or if it's hyphae? It looks like it's hyphae. And the fact that it's hyphae, then it's either aspergillus or mucor. Of the two, if we look at the angles of branching, I would say acute. So I would say aspergillus, and it's a little more septated than the mucor is. So I would go.
Now I tell you, you went down the wrong path, but it's because you know that this is a GMS stain, which is very impressive. So I'll give you full marks for that. And I'll give you full marks for knowing that the GMS stain should pick up a fungus. But I'll give you a little stem, and then I'll tell you why this is not that. Okay, so this patient has a history of pulmonary alveolar proteinosis with a crazy paving pattern, which you can see there. And then after a while developed a mass in that region, and there was also a mass in the brain.
So there's a filament, it's filamentous.
Yes.
So can you tell us whether it's a weakly acid fast staining or not?
It is weakly acid fast.
Yeah.
Right? So what is it?
Nocardia.
Nocardia, yeah. So the trick is, and what I'm showing you is the real life. So in real life and pathology, the acid fast stain doesn't work. So it's not positive, and only the GMS stain marks them. But the acid fast stain actually does work in microbiology, and it does work in cytology where the tissue is not fixed. So there it is weakly acid fast. And for the boards, you absolutely must know that it is weakly acid fast. But remember that the GMS will stain it. And just like you said, these are filamentous. The differential of the filamentous bugs is nocardia and actinomyces. But in actinomyces, they're clumps, round clumps of these bacteria, not individual filaments like this. And of course, if you have a stem with, alveolar proteinosis, lung mass, brain lesion, then you're already, down the correct track. All right, very good. I've been very impressed. Go ahead.
In the top, towards the top right of the GMS stain, I think we're getting confused. We're kind of mistaking those filaments for hyphae. Is that just because it looks like there's like acute angle septation? Like I can see what.
And they branch. Yeah. They branch sometimes. So these are the actual bugs.
Oh, okay.
There's a lot of debris in the background, which is not bug at all. Not this stuff is not real. But this is bug. This is bug. Okay. And I think you're right. There is some degree of branching there in some of them. But I'll tell you, just from a morphologic point of view, these are too slender to be fungi. Fungi are a little bit bigger than this. Thicker, bigger. They have septa. This has none of that. But you were absolutely right to think, when you see a green stain, think fungi. This is the only exception. And they'll never show you a GMS. This is I'm showing you a real life case. That's why I'm showing you a GMS. They will show you an acid fast stain, and you should just remember weakly acid fast. So yeah, sorry for misleading you like that with the picture. You're all drawing.
Won't forget it now.
Yeah.
Yeah,
Ra-
good,
ra-
good.
Would
All
rather
right.
get it wrong now than on the boards.
Yes, they're on the boards. All right, guys, this is harder, but let's see if anybody has any guesses on the morphology. By the way, there's only one nodule here, but it's, there's two cuts of it. There's only one. Two sections of the same lesion. Anybody know what this is? Patient is I don't think the stem will help much. 56-year-old man with a solitary, well-circumscribed lung nodule, never smoker. The nodule has been fairly stable over a period of 2.5 years. Not speculated. And not PET positive. Anybody?
Is it a fibroadenoma?
You're very close. Yeah, you're
Some kind of adenoma.
the concept is correct. It's just the name.
Yeah.
The concept is right. What is it called when you have a benign lesion? So I'll tell you that this purple stuff is cartilage and the white stuff is fat. Do you know what that's called?
Hamartoma?
Hamartoma. Very impressed. I'm very impressed. Yeah. So hamartoma is very common benign lung, at least from a lung pathologist point of view. Very benign, very common benign lung lesion. And what they will show you in the picture is cartilage, which looks purple like this, mixed with fat, which looks white like that. And there are more nuances to that, but you really don't need to know that. Just as long as you know that this is in the differential of a benign lung nodule and has a mix of cartilage and fat, you should be okay. Anybody else? Anything?
No, that's good.
All right, let's move to this is a good one. Tough. This is tough. Let's see if anybody knows from low mag. I'm not telling you on purpose what the immunostain is, because once you know that, you will get it. I want you to try and guess from the morphology. So what is all this stuff? If no guesses, I'll give you a little bit of a stem. This patient is a, let's say, 45-year-old woman who was who broke her clavicle and had a chest X-ray, and they saw some vague opacity, so went to CT. On a chest CT, they found innumerable multiple bilateral lung nodules suspicious for miliary infection or metastasis. And some of these, all the nodules were a few millimeters in size. Many of them were cavitary. There was slight upper lobe predominance. Patient is a 45 pack year current smoker.
Oh, yeah. You said smoker, right?
Yes, correct.
And nodules that are cavitary, I would say PLCH, right?
Very good, very good. Okay,
Yeah.
you got it, man. This is beautiful. So this is absolutely the history we get in all these PLCH cases that come to pathology. And what you should see on the path is these little lesions in the lung that are called stellate nodules. They're called stellate because they look like a star. They're slightly irregular. They're not round. And the stellate shape comes from the fact that the Langerhans cells and the fibrosis are extending into the alveolar septa from the middle of the lesion. They're supposed to be peribronchiole, but actually you see that blood vessel there? They're not so much peribronchiole as they destroy the bronchiole. Yeah, so I guess they are peribronchiole, but they destroy the bronchiole that's involved and form these little stellate lesions. Now, from that, can you guess what the immunostain should be?
CD1A.
CD1A, perfect, yeah. Either CD1A or S100, that might show up in your stem, or there's a newer one called Langerhans. Either one of these three, if they're in your stem, you should know you're talking about LCH. Remember, some patients will have cysts and no nodules. Some people will have nodules and no cysts. But if you have nodules and cysts both, and the patient is a smoker, you pretty much are, dead on correct with the LCH. Any questions about this? Very, very classic entity.
Is this kind
No?
of one of the only situations that they give us a low mag view?
Yes, yes, because the low mag is so characteristic, multiple small stellate nodules. This is, for a lung pathologist, this would be a very fair question. For you guys, it's not fair without the stem, but you might get something. With an appropriate stem, I think it's a good question to ask. All right. Guesses on the picture alone. You've got 15 minutes. I'll give you a stem which should immediately get you to the answer. Ready? This is a 69-year-old construction worker from Sonora, Arizona.
Coxie?
Yeah. Yeah. Hopefully they don't make it that simple for you, right? Like, I mean, yeah, but basically these are the Coccidioides spherules, these big things. Each one is a spherule. And within that, the purple stuff, those are little endospores, like small endospores that are within the spherule. Sometimes you'll see the spherules have ruptured and all the endospores have come out. But the background pink stuff that's in there is necrosis. So this is actually the middle of a necrotizing granuloma, and all these, spherules are in there. I don't think morphology, it's not fair for you guys to get this on morphology. But if they give you a stem with a lung nodule and the appropriate location and this, I think that's fair to call it Coxie. Right?
Yep.
Questions? All right. Okay, guys, this is tough also, but I'll give you a little stem which will give you the answer. I want to see what you think from the picture alone.
We have a vote for neuroendocrine.
Okay, very good. You're correct about neoplasm. So you're half the way there.
Are those the Reed Sternberg?
They look like that, isn't it? Like they have big nucleoli. Yeah. So you're yes, they're not Reed Sternberg cells, but they look very much like that. Okay, should I give you a little bit of a stem? 47-year-old never smoker woman. Oh, how easy should I make this? Okay, let me try. Let me try not so easy with a mediastinal mass.
Adenocarcinoma?
What's that?
Is it adenocarcinoma?
No. Okay, anterior mediastinal mass.
Oh, thymoma.
Thymoma.
Thymoma. Yeah, that's right. So in thymoma, what they will give you if they ever do that, which I don't know if it's fair or not. If they say myasthenia gravis, then it's fair, right? So if they say myasthenia gravis and then tell you anterior mediastinal mass, so what you see is these larger cells are actually the neoplastic cells. They are epithelial, and the smaller cells are not neoplastic. They're just passengers. They are lymphocytes. So they are thymic lymphocytes. So if you see a mix of epithelial cells and lymphocytes in an anterior mediastinal mass, that's, for your purposes, that's thymoma. Okay, guys? Questions? No? Okay. So let's go to this one. Oh, tough one, but let's see. With the stem, you might get it.
I think that's a caseating.
Caseating granuloma.
Yeah, right?
Caseating granuloma?
Yeah.
Yeah, you're on the right track. And actually, I'll tell you, I had a case from the Middle East where actually they called it that. The patient was treated for tuberculosis and nothing happened. So the nodules didn't change.
It's non-caseating.
So now the group is saying it's a non-caseating granuloma.
No, it's not.
That's not.
It's
Yeah.
still caseating.
It's neither caseating nor non-caseating.
It's a granuloma. That's what I'm saying.
It's not a granuloma.
That's how.
It's not. It looks. I will grant you, it looks like a granuloma, but it's not. Okay, here's the stem. This patient has bilateral lung nodules, multiple bilateral lung nodules, and some hilar adenopathy with eggshell calcification, and has a significant occupation. What's that?
It's a silicotic nodule.
Correct. Very, very good. I'm impressed that from that stem you got it. Okay, so this, the difference, it looks very much like a granuloma, except the center of it is fibrotic, not necrotic. And then the periphery of it is just dust-laden macrophages, where all the silica and silicates are located. So it's not fair to do it by morphology alone. But if you had the stem, if the patient was a sandblaster or did denim sandblasting, or was working in making countertops or something like that, or was from West Virginia, I think it would be a fair question with this stem. So you're right. This is a silicotic nodule within the lung parenchyma. Questions, guys? Anything?
With the silicosis, there's like an increased risk of tuberculosis as well. So it probably wouldn't be fair game for them to show us a granuloma as well, right?
Yes, no, would not be fair. Would not be fair at all. In fact, when tuberculosis gets superimposed, it really complicates the histology too. So not at all fair for any board question. Yeah. Okay, guys. Next question. All right, let's do it from the picture alone. We're 9 minutes from End of.
Crypto.
Oh,
Crypto.
beautiful, beautiful. Man, you've been really paying attention to that previous lecture. So explain to your colleagues why. Explain.
So we ignore the nucleated cells, which are just inflammatory, and you look at the organisms. So they're yeast form. So your differential narrows to yeast. Inside the yeast, it's either the histo, cocci, blasto, or crypto. In this one, you can see the clearing around and you can say that the clearing, then it's either histo or crypto. And because of the size and how they're budding, crypto is more likely than histo. Crypto, I think, is size is uniform, or sorry, size varies, and histo is the size is uniform. Yeah. So this one is crypto because you have
so
the
look
clearing
at the,
and
you're
the budding.
absolutely like everything you said was absolutely perfect. But look at the difference in size. See that? So there's a very small one and a big one. So that goes with crypto. Yeah. So the more the variation in size, the better it is for crypto. And the more the uniformity in size, the better it is for histo. Yeah, very good description. Very, perfect. Anybody with any questions about cryptococcosis? Do you know what stain? They might put a stain in the stem, in which case it'll be diagnostic. What stain could they put? Mucicarbon. Yeah, correct. It's a mucin stain, and then this part of it, characteristically, this part all turns orange if you stain it with the mucicarbon. They say it's the capsule, but I don't believe that. All right, so let's go to the next one. Okay, this is tough. I don't even think it's fair. I'll tell you, this patient is taking a medication for a cardiac arrhythmia that caused this lung reaction. Can you guess what it could be?
Amiodarone.
Yes. And what is the characteristic thing you see in lung disease with amyloidosis?
Lipid-laden macrophages.
Yes, correct. Foamy macrophages, and the foamy thing comes from lipid. And of course, foamy macrophages are one of the least specific findings in all of pathology. But, they do happen in amyloidome. So it's not wrong, but it's just that it's not at all specific. And then you get this, the thing I'm showing you here is organizing pneumonia, just like in the previous case. So any kind of organizing pneumonia, DAD, interstitial inflammation, combined with foamy macrophages would be the right tissue reaction for amiodarone toxicity. I don't know if it'll be fair for your for the boards, but I thought I'd show you an example. All right. How do I get rid of this thing? Go back to annotate. How many more should we do, guys? 2 more? 2 or 3 more?
Yeah.
2 or 3 more? Okay, where's the clear? All right. Ooh, this is a great one. And I think this is very fair for the boards. Anybody know what this is? Tricky on the... I can guarantee you will all get this right if I give you this time. Guaranteed. Anyway.
UIP?
No,
UIP?
no. Fair. I know why you're thinking that, but no. So this is a, let's say, 41-year-old woman with multiple bilateral lung cysts.
Lamb.
Okay. Now that you know it's lamb, tell me what this thing is. So what is this thing here?
Well, I think the pathophysiology of Lamb, if I remember correctly, is smooth muscle hyperplasia.
Correct. So this whole thing is a cyst. You're right. Yeah. So smooth muscle, and this is the smooth muscle. This little wisps of smooth muscle in the wall of the cyst, that's the abnormal smooth muscle. And why are they abnormal? Does anybody know what they stain with that makes them different from usual smooth muscle? What's the marker that you ask the pathologist to do? Anyone?
Yeah. It's on the tip of our tongues, but we're trying to HMB. Yes, that's
HMB
it.
what? HMB?
Oh, HMB 45.
Yes. Okay, HMB 45. Correct. All right, guys. Do you understand now? So it's basically a hole. There's just a cyst, and then in the wall of the cyst there are little abnormal smooth muscle cells. And if they tell you HMB 45 woman, you're pretty much done.
HMB 45. Yes.
HMB 45.
Thank you.
Questions? Any questions?
Good.
All right, we're down to the last two. I think we're in time now. Let's do two. Oh, okay. Tough one, but I think you might get something like this, something along these lines. Any idea?
This is an idiopathic pneumonia.
Okay, you're
yeah,
close. Yes.
Yeah, and of the patterns, UIP or
Which one is it?
NSIP.
I know NSIP's cellular NSIP or fibrotic NSIP. Yeah.
Yeah, it looks like NSIP, doesn't it? Yeah.
Yeah.
So let me tell you, this is a 45-year-old extremely heavy smoker with 60 pack year history, with a low DLCO, bilateral ganglioside opacities like you see here, and no connective tissue disease or anything, and no connective tissue disease, no underlying cause that would explain NSIP, just a heavy smoker. Can you guys think of what this could be? So a thing that looks like NSIP could actually be, so in the old days.
This is it's
Desquamative.
Yes, that's
IP,
what most people except for me like to call this DIP. So DIP, and if you don't have that and there's only a little bit of these macrophages, do you see the macrophages filling the air spaces?
Yeah.
So in so-called DIP, you get interstitial thickening plus the macrophages and diffuse. In RBILD, you get focal around the bronchioles and not quite as diffuse. I think both terms are absolute nonsense. Some of the worst terminology in pathology. I call it smoking-related interstitial fibrosis, SRIF. But as long as you know that it's some kind of smoking-related ILD, you'll be in good shape. It looks so. Just remember, it can look very much like fibrosing NSIP. But look for that alveolar filling. Look for the history of heavy smoker in the 40s usually, low DLCO.
So you said that with if it's just fibrotic NSIP, then you wouldn't have the alveolar macrophages that you're
typically not.
Earlier?
It's usually an interstitial thing, which is not usually this pink. It's a mix of pink and blue because there's some lymphocytes in there and some fibrosis. So it looks similar, but it's not identical. And with NSIP, they really shouldn't be giving you an idiopathic case. Usually they should give you some sort of CTD associated NSIP if they want to be fair to you, but who knows? They might be cruel. Okay, guys, fair? One last one. Okay, let's end with this one. This is a really good one to end on.
You know it?
Our fungal expert probably knows what it is.
Blasto. It's Blasto.
Okay, go for it. Tell them why. Beautiful.
You want to explain it? Yeah, they're calling the yeast in the broad-based budding yeast in the middle of the screen. That's kind of the reason for blasto. Yeah.
Yes, blasto, broad-based budding. So this is one yeast. Let's say this is the mother, and then this is the other yeast. Let's say the daughter, and then the point at which they're connected is a broad point like that. So that's broad-based budding. If you had histo or crypto, the point at which the mother and the daughter would be connected would be a narrow point. So that's called narrow-based budding. So the only one that really ever shows you broad-based budding is blasto. The other couple of things about blasto, it has a thick wall. You see the wall there? And it has this purple nuclear material there. The other thing about blasto is that the background often has neutrophils. So it's a suppurative necrosis. This picture doesn't have a great example of that, but the necrosis is typically suppurative necrosis. But if you want to just ignore everything and just go for one thing, the broad-based budding is the best. It's basically pathognomonic of blastomycosis. Okay, guys.
Awesome.
All right, we'll end there. Hopefully you guys learned something, and we'll hopefully we can post this. We'll post the entire thing on YouTube so you guys can watch it and others can watch and learn from it. If you're all okay with that, then we'll proceed like that.
Yeah, we'll send you the MP4.
Okay, sounds great.